Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, ASRA Wrap. I'm your host, Raj Gupta, coming to you from Nashville, Tennessee. And we have a fantastic show for you today. We're going to be talking to three experts in the pain management field today about a upcoming symposium that ASRA is hosting. And I think you are going to be blown away by what they've put together. I'll go into the details of their bios and introduce my guests in just a few moments. But before we get started, I do want to give you a couple of announcements about things coming up for the society. So Azure Pain Medicine has a ton of stuff happening within the society, and I want to highlight a few of them. So first off, most importantly, is that in this spring meeting, the Regional Anesthesia and Acute Pain Medicine meeting that's coming up this spring, it's April 20th to the 22nd, and it is going to be at the Diplomat Beach Resort in Hollywood, Florida. This is right between Fort Lauderdale and Miami, Florida. It's really close to both airports, really close to Miami, and it's a beautiful hotel with a wonderful beach right there outside the hotel. We are going to be celebrating the 100th anniversary of the founding of the original American Society of Regional Anesthesia. That was in 1923 by Gaston Labat. It's a big deal. We have a lot of special guests, a lot of really big names from the society that you've known for many, many years are going to be coming to this meeting. So I highly encourage you to register and be part of the meeting. There is an early bird deadline coming up February 23rd. This is where you can get a discount on your registration. So if you can, go to azra.com, make sure you register by February 23rd and get that early bird discount. Also, go ahead and join us on social media. We're going to be talking about this meeting leading up to it for the next several months. And so if you join us on hashtag ASRA Spring 23, ASRA Spring 23, or hashtag ASRA 100, the number 100. We're going to use both of those to talk about this meeting and all the really cool stuff coming up at the spring meeting. So I really want you to see that. The other thing is there is a bunch of events coming up for ASRA in the next few months. So if you just look through this, there's a headache and facial pain case presentation. That's a web meeting coming up in just I think that's tomorrow, actually, if you're watching live. On February 9th, there's a pain program directors virtual meet and greet. Great way to meet the program directors for the fellowships you're applying to. It's a hot topic special live webinar on job searches, practice evaluation, and how to have a successful practice. I'm going to skip this next one because we're going to talk about it at length. And then April 4th, there's a building of compliance in pain medicine. Of course, the spring meeting, and it just goes on and on and on. There are so many great events coming up online and in person for the society. So I encourage you to make sure you go to azra.com, look for the events calendar, and look at all the upcoming events. Wonderful, wonderful stuff. Now, I do want to get to our main topic for today. And to do that, I'm going to introduce our guests. And we have three wonderful guests. First off is Dr. Hesham Elsharkawy. He's a staff member at Metro Health and associate professor at Case Western Reserve University in Cleveland, Ohio. Dr. Elsharkawy's research focus has been on the development of new technologies, new pain procedures, and the transition from acute to chronic pain. Really important for today. This interest led him to establish the Persistent Perioperative Pain Special Interest Group within ASRA, and he has experience in research, has contributed to the field of regional anesthesia, and has been invited to many lectures and workshops in both national and international conferences and numerous grand rounds. Dr. Elsharkawy is also really actively involved in multiple research projects and multi-center studies and received grants to support research projects. The core of his educational activities in teaching residents and fellows in different clinical settings, as well as during formal lectures, journal clubs, simulations, workshops, and problem-based learning discussions. If you've been anywhere near ASRA Society, you've seen Dr. Elsharkawy. If you've ever read anything in this field, you've read his work. He does phenomenal stuff. Hesham, how are you? Welcome.
Hi, Rich. How are you doing? Thank you very much for the introduction. It was a great introduction. Thank you very much.
You're welcome. I'm gonna introduce our other two folks here, then we'll continue talking. So next up, Dr. Hance Clark is the Director of Pain Services in the Pain Research Unit at Toronto General Hospital in Canada. So we're already international in this conversation. He is the Knowledge Translational Chair for the University of Toronto Center for the Study of Pain and Associate Professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto. Dr. Clark is authored more than 150 peer-reviewed publications and been invited to speak on pain control, cannabis, opioid crisis, not only to people like us, but to the House of Commons in Ottawa, Canada, and elsewhere around the world. In the spring of 2022, he became the president-elect of the Canadian Pain Society. Dr. Clark, Hance, how are you? Welcome.
How you doing, Raj? Thanks very much. Pleasure to be here.
And this last introduction is Dr. David Edwards. He's the associate professor of anesthesiology and neurologic surgery and chief of the pain medicine at a small hospital called Vanderbilt University in Nashville, Tennessee. I say that because Dr. Edwards is my colleague here at Vanderbilt. He oversees care of patients in urban and rural specialty clinics that treat perioperative, acute, and chronic pain, cancer pain, pediatric pain, and substance use disorder. Dr. Edwards' research program includes National Institutes of Health funded investigations of outcomes after perioperative opioid exposure and trials in drug development of non-opioid options for treatment of pain and opioid use disorder. He teaches a course on pain, policy, and addiction at Vanderbilt Medical School where students learn to impact policy. And let me bring him on the screen. Dave, how are you? Good to see you.
Good evening, everyone. Nice to be here with everyone.
So that was a mouthful. You guys have such a huge bio. It takes me forever to get through that part of it. But let's talk about the program that you guys are putting together. I'm going to put this on the screen briefly before I let you do the full introduction. Hesham, this is the, let me switch this over to your meeting. So this is the Chronic Postoperative Pain Symposium. And I'm going to remind people of the date multiple times. It's Saturday, March 11th. 9 a.m. to 4 p.m. Eastern. And this is a virtual meeting, but you're going to be blown away at what kind of virtual meeting this is. So we'll get into the details of that in just a second. So make sure you go to ASRA.com and go to the link for this meeting. You can go ahead and register for that right now. So I want to talk a little bit about this meeting. Hesham, you want to do a quick introduction about the meeting and what inspired you guys to put this together?
Sure. Thank you very much, Raj, for the introduction. I'm thrilled to be here with you and Dr. Clark, Dr. Edward, that these are really pioneers who's with others make me interested in this. So I appreciate their time and their experience. So this started in 2017, around that time. My practice was mainly acute pain, regional anesthesiologist, but then I see a lot of disconnect between the acute pain physician, as personally, I'm an acute pain physician for decades, and a lot of patients, they lose follow-up with us, and they come later to the chronic pain colleagues, already late, and there is a big disconnect between the acute pain, it's well-established specialty, and the chronic pain also definitely it's well-established for decades. And a lot of us are kind of the same, or most of us anesthesiologists, even other specialties, we are physicians, we connect in the conferences, but in the clinical practice, there's a big disconnect. And then Dr. Clark and Dr. Badema from Duke and Dr. David, I learned the great things that they do with their practice. So at that time, I reached out to the ASRA leadership to establish a special interest group regarding the chronic postoperative pain. And at that time, I started to go into the chronic pain, and I became gradually a chronic pain physician. And when we established this group, there's a lot of interest from both sides, but this gap, it's scientific gap, clinical gap, research gap, even at the level of organization, the organization, either acute organization or chronic organization, and the meetings, it's usually acute pain meetings, regional anesthesiologist, or a purely chronic pain meeting. So the idea came that let's do some effort to try to close this gap between those two worlds. And I think since we started this group, we did broadcast, we even have some publications out of this, and our work also led to the symposium, the Chronic Postoperative Pain Symposium. We did the first symposium in 2021, which was, I think, a great success that lead us to, plan for the second symposium, the upcoming symposium, which will be in March 11. So, I mean, I don't want to go into the details of the chronic pain after surgery itself. It's a huge problem, and it's kind of the most common complication after surgery. I mean, the surgeon maybe not admit that, but this is the most common complication. And there's a lot of potential to help patients, and a lot of potential for medication management, for innovative kind of a service and practice-wise, and also a lot of potential for interventions in that area. So there's a great potential because it's a gap, it's an unmet needs. So definitely it's a huge opportunity for us to intervene with many aspects. So we worked for the last 6 months or more with Dr. Clark, Dr. Edward, and the rest of the steering committee, with Dr. Narous, the current ASRA president, Dr. Ed Mariano, Dr. Shalini Shah, and Dr. Al-Kasabani. We have a very good program for you. And it is different than the first symposium. There is some basic subject that may be kind of close to the first symposium, but there is a new subject to discuss, and more interactive discussions than just lectures. And then the main new things in the upcoming symposium is the workshops.
We'll get to those in a minute. Let me, I want to bring in the conversation. I still want to focus on the topic for a second, and then we'll go into the mechanics of the symposia itself. So Dr. Clark, in Canada, I'm sure you guys are facing some of the same challenges, but maybe some of the different mechanics that we do in the States. Dr. Elsharkawy talked about acute pain physicians, chronic pain physicians coming together in putting this thing together, because obviously both of them see the need. The definition of chronic pain is usually after 6 months, but that's a long time after surgery, and 6 months to be defined as chronic pain. There's a huge, as he said, that there's a huge gap there. What have you guys seen in Toronto and in Canada largely about this gap, and what kind of efforts have you guys put into connecting those dots and filling that gap in from acute to chronic?
Yeah, Raj, great question, right? So this is, I think it transcends even Canada. US is a global issue. We've got over 200 million surgeries happen worldwide annually. And so we're looking at, 5 to 7% of individuals probably have a persistent pain issue at a year following surgery. So it's something that was, high on our radar based on the data that we had for a couple decades coming out of, our lab here with Dr. Katz and some of the other folks. We thought, let's build something. And so what we decided to do, as Hesham rightly described, is try to connect this gap between acute and chronic pain. So I'm sure the wait lists in the US are similar to some of our wait lists here, but if someone had a problem postoperatively, their journey would be typically they see their surgeon, they may or may not be asked about pain, they have their primary care physician, and about 6 months later, as you've said, they realize, oh, this pain's not going away. And by then they've been started on, multiple medications, whether it's opioids, et cetera, but never really on some of the meds that can potentially help them early on. And so you hit it on the head. So you have about a 6-month window before an acute pain problem becomes a chronic pain problem. And so that's the time of intensive intervention. And I think it's some of the things that you'll see in this symposium that's been built out, some of those interventions and some of the things that we can try to consider bringing in much earlier on. And so, we've tackled it from a very much a mental health standpoint, so an addiction standpoint, anxiety, depression, all the things we know that contribute to people who go on to have problems. And that's been our mainstay of our kind of interventions. And so it's now time to build in all of the other possible tools in the armamentarium to help these folks earlier on so that they don't end up being chronic pain patients if we can help it.
David, I know some of the work that you've done at Vanderbilt to kind of create this transitional pain service and some of the challenges that have been faced by it. Some of those are even financial, trying to figure out how to pay for a service like that does not have an existing, base of support to it. Acute pain has a sort of established setup. Chronic pain has a sort of established setup. I think that part of the purpose of the symposia is to teach people how to build it at their own location. I think there's a growing awareness of the need, although maybe not a full understanding of everybody involved in the chain of care. Amongst us, there's a growing awareness of the need. Talk a little bit about how to build that service, and where do you think the symposia can help people understand and build that in their own place?
Sure. I think one of the kind of fun and I've experienced being a part of Dr. Hesham's symposia over the years is the chance for us who are practicing this type of pain in our different spheres of the world to get together and discuss how it's being done elsewhere. I think the more we meet and the more we get together and talk about this, the more we understand each other's needs and can share how it works in our own hospitals, our own area of the world, how the mechanics work, how the finances might work. And then we separate and we can translate what we've learned from each other to other areas of the world, to our own hospitals, whether they be private practice or academic centers. How does it specifically, or how would a service such as a transitional pain service, a perioperative surgical home, or an enhanced recovery after surgery service that moves a little preoperative and follows up a little bit postoperative, how all these can work financially? Everybody has to figure out how that works in their own hospital. I have a colleague who used to work with us as a surgeon at Vanderbilt who recently moved out into the community and said, we don't have any of the wonderful services we had at Vanderbilt, and everyone's prescribing opioids. Help. How do we set this up? I think that's a common.
Those small places are even a harder question. I mean, we got big academic centers and
trainees, right? They go out into the world.
Yeah.
They love acute pain. They love chronic pain. Now, how do you actually make it work? And we hope to answer some of this at the symposium.
So Hesham, let's talk a little bit about the symposium itself, and some of the things that you guys have done to make this worthwhile for people. And then also, for those of you listening live, feel free to put comments down below. I'll see those and I'll bring those up to the guests, questions or comments. So feel free to put those in the bottom if you're watching this live. Love to hear your thoughts and opinions on this topic and questions about the symposium coming up and what you might learn. So I'm going to put up on the screen the program itself so we can kind of navigate through this a little bit. Hesham, you want to take us through some of the idea? You're particularly at the beginning of the session, talk about these two parallel sessions.
Sure. Thank you, Raj, again, and I appreciate all the attendees. They just interact and send us questions and make it like an informal discussion today. So we want to put a lot of content as much as possible, and especially with the addition of workshop, this limit the time of like lecture. So we split the first half of the symposium into lecture and interactive discussion with parallel sessions. So when you see in the schedule that the first parallel sessions about the basic translation from a basic research to practice, use of artificial intelligence and predictive modeling of the transition. As you see, the list of the faculty, there are expertise with Dr. Shane Mackey, Eric Schwenk, and we are invited Dr. Patrick Tigg, University of Florida, David Clark, Stanford, and Dr. Schreiber. And then at the same time, there's another session discussing a multidisciplinary approach with emphasizing addiction and also the psychotherapy and the psychiatric aspect of the chronic postoperative pain. And I'm trying also to give some solution to close the gap between the acute and chronic pain. Those are two parallel sessions, and I need to emphasize that the symposium is recorded. So all the attendees, they're gonna sign for this. If they were able to attend only one of the parallel sessions, the other one would be recorded. They can listen to it at any time for a whole 1 year, and they can still get accredited like a CME credit. So also,
yeah, that's really important. This whole symposium is approved for CME. For those of you guys looking for CME, what a great place to get it is to log into this on a Saturday. Yeah, exactly. And as you, just to emphasize, if you want to listen to, Patrick and Sean, but don't want to miss Lynn and Hesham talking, you'll still be able to do both of them because you'll be able to listen to the recording. But what do you mean by interactive during this session? So we don't usually get interactive with these webinars.
We're gonna have a live part, so it's not like only a lecture. The faculty will present a lecture, but a short lecture. So the big part, around like maybe 50%, 40% of the time of each session will be allocated to the interactive discussion between the faculty themselves. Because as Dr. Edward and Dr. Clark say, that we learn from each other. Because each model may be different. What fit in their system maybe not fitting with me. So when we interact together, we learn a lot. And what I learned from Dr. Edward, for example, in the financial aspect, actually, I presented with his permission in my hospital 2 years ago, and actually it helped. I tried with a different way, but during our previous symposium, I learned from him and I changed my approach, and then I was successful. So we interact together, and also all the attendee can post questions so we can answer them live. And then we're going to move to a non-CME break. And then after the non-CME, we have another 2 parallel sessions also. The attendee can attend whatever option they want to. And the second parallel session in mainly interventional. So one session about cryoanalgesia, about radiofrequency ablation and peripheral nerve catheters. We have Dr. Brian Elfeld, we have Max Eckerman from Texas, Dr. Ed Mariano, and this session will be moderated by Dr. Steve Cohen and Dr. Broventano. And then the second about the peripheral nerve stimulation, because it's a great role of peripheral nerve stimulator, either temporary or permanent in the subacute stage. So we dedicated a whole session about the peripheral nerve stimulation, and this will be moderated by Dr. Konstantin Slavin, who's a well-known worldwide expert in neurosurgeon, and myself, and also we have 3 great faculty, have a lot of experience with the peripheral nerve stimulation implants, about the temporary and the permanent, and also patient selection, because there's no gold standard when to select those patients for those devices. So patient selection is also important. And then we're gonna go to the
so I want to interrupt you there for just a second. So I want to emphasize a point here. So we talked about at the beginning that this is a really a symposium for acute pain physicians, regional anesthesiologists, and chronic pain physicians. And I want to point out on this, if you look at the procedures, the interventions, so many times we talk about these pain talks, and the interventions are all things that fluoro in the outpatient environment, spinal cord stimulators, and things that acute pain physicians are typically not doing. But here you guys are presenting quite a spectrum of options that do cross those lines. And there are acute pain physicians doing many of these procedures: peripheral nerve stimulation, implants, radio or cryoanalgesia, starting to kind of enter into, Brian Ilfeld's an acute pain physician primarily. Ed Mariano is an acute pain physician. Shalini does chronic pain. So, these things are crossing both of those lines and allowing people to have options for these people who are in this phase from the hospital to hopefully never getting to the chronic pain state, but if ultimately at some point that outpatient environment where they're being intervened on in those environments. So it is appropriate to see that there's options for everybody in that spectrum to learn something new and incorporate that into their practice. Sorry to interrupt you there.
No, it's perfect. And this is exactly one of the main goals of the symposium, is to close this gap. And interventions, medications, the experience from both sides are needed. And now, this will lead us to the last session, where even because of it is very important, I put it just in a separate session, no even parallel session. So who attended, this will be the only session at that time, which is a transitional pain service, will be moderated by Dr. David Edward, Mary Hannah from John Hopkins, and Dr. Clark will be there, because without really a service, the transitional pain service, it's very difficult to be successful in managing those patients, because it's not that simple. It's not just one medication or a needle. It's a whole complex treatment for complex patients. So that's why we emphasize the transitional pain service in a whole session.
Hance, can you talk a little bit about, so this topic you have here with Padma on making it financially profitable? You're in Canada. Why do you need it to be financially profitable? You guys have nationalized healthcare, right? Everybody, you don't have to worry about that stuff.
Yeah, it's very interesting. When we published our roadmap years ago, we talked about all these individuals we had in the clinic, and it was always neat to see some of the presentations at ASRA talking about our model costing all this money. And so the fact is, our model doesn't really cost that much money. And I think it goes back to what David was speaking about earlier. And one of the things that our federal government funded us for was to create a roadmap. And so if any of you want to just take a look at our website, and I'm sure we'll share that on the day of the symposium, but we have a kind of a how-to guide, and it's really just this how-to guide for policymakers, for administrators, for physicians. It talks about, here are the tenets, here are the pieces you have. How do you build something that fits your hospital and fits your service? And so the concept that, you need 5 FTEs to do one thing and 6 other FTEs to do another isn't necessarily the case. You really just have to build something that helps your institution. And every institution that's doing major surgery has to and should. I think it's incumbent on them to build something to help that 5 or 10% that struggle. And we're really good at what we do. We like to claim that we help a lot of people, and if we didn't, we wouldn't be doing what we do. But those that sometimes don't do well, they get lost in the shuffle, and they end up clogging up the system. And so this is really an important aspect, and how you go about building it is really up to you and your institution.
I saw a great talk by Dr. Amit Pawa from London at one of the ASRA meetings, and he was given a similar question: why do you have to worry about finances in a nationalized healthcare system? And his way of putting it was, it's still resources. There's always limited resources, no matter if it's direct billing or resource allocation of some sort or another. You're given a fixed amount of resources, whether those are dollars, equipment, space, personnel, and you have to figure out how do you allocate that to the mission and goals that are the most effective for outcomes. So you guys face the same challenges. Maybe the language is a little different, but it's really the same thing, honestly.
Yep. And when you look at the numbers we talk about, and we're about, we're your little brother. So you're 650 billion a year in terms of cost to chronic pain, and we're about 65 billion. So that's 1/10. If you look at what we claim the number is from a chronic post-surgical pain standpoint in Canada, it's about 1.8 billion. Multiply that by 10, that's probably 18 billion in the US to 20 billion a year. So those numbers can be very clearly allocated to the things we're talking about. And you can certainly, if you can, start to implement some of these potential procedures that we're talking about in the future, perhaps we could start to reduce some of those numbers and the ability to reduce the number of people that move on to that chronic pain spectrum.
And Dave, you want to talk about how, this is investment, not spending. We're the amount of expense related to the existence of chronic pain, and hopefully curbing that early on and explaining that to leadership. How do people cross that line?
I think all you need to do is talk to a bunch of surgeons who have taken advantage of our services, and then
you have their cell phone numbers to hand out today.
Take it away briefly and watch the phone calls come in from those around you in administration who realized how helpful it was to help keep patients out of the emergency room, to keep them from returning back to surgery clinics. When you're helping them transition, we're helping them setting the expectations early on about what they're going to experience for acute pain, helping them get through the hospital experience, and preventing them from returning to the hospital for expensive care when they can really just be transitioned smoothly to the outpatient center. I think that's what we're all talking about as acute pain and chronic pain physicians, working together and making this easy for our patients.
Yeah, it's a really interesting topic you bring up about them coming back to the hospital. I mean, I know at our institution, the hospital is always full, and anything that we can do that reduces the chance of another person having to occupy a bed in the hospital, that is now making a lot of sense to our C-suite colleagues who are looking at every bed as a valuable limited resource. And this is part of that process. Absolutely. Hesham, you want to talk a little bit about the really innovative thing that you guys are doing in the second half of the day, which I don't think we've done this at a virtual ASRA conference yet. Is hands-on expert demonstration.
Yeah, thank you, Raj, again. And one or many feedback that we got from the first symposium that we need more of intervention and a lot of procedures also that can be used in the subacute stage. The attendee want to learn more about those procedures. So we listen when we hear feedback, and ASRA and the ASRA leadership also put a lot of resources in the recording and those workshops. So what we end up doing and selecting a subject or certain procedures or certain areas of the body with a potential intervention that can be used in the chronic postoperative pain. And our our eyes, our base kind of goal is to still to close the gap between an acute and chronic pain. And we have some specific also feedback from the attendee with certain procedures. I will give an example. For example, the use of X-ray or fluoroscopy in the acute pain site. There's a great need and also a great use of X-ray in the acute pain ward, from thoracic epidural, lumbar epidural, specifically in certain tough patients. And there is, I can say, a lot of appetite, a lot of interest from the acute side to learn this. So what we did, we recorded those procedures in the previous meeting with a lot of experts in those areas. Some of those workshops are recorded in a cadaver. So actually they did the actual procedure from A to Z. And during the performance of the procedure, the faculty discussing some indications and some tips to make the procedure successful, and also some use of this procedure is specifically for chronic postoperative pain, because some of those procedures I just use in the chronic pain wards, but they have a use in the chronic pain. So the faculty, while during the procedure, they're discussing the potential role of this procedure in the chronic postoperative pain. Part of those workshops also are done in the volunteer, like scanning, but again, the faculty discussing the use of this in chronic postoperative pain. And then during the live sessions, during the symposium in March 11, so the attendee will see the recording of this demonstration, and then he's gonna have a time to discuss this procedure or this intervention or description of X-ray, for example, with the faculty. The same faculty that present this and recorded this, he's gonna be available for questions. Definitely, we're gonna miss the really hands-on from the attendee, but he's gonna watch the procedure, ask question, tips when to use this, and any related questions regarding this procedure itself.
Yeah, and if you saw in that program, there's stuff for chronic pain physicians, acute pain physicians, and I'm going to cross promote here is for those of you interested in learning stuff about using fluoroscopy for acute pain procedures, particularly neuraxial procedures. We actually have the first time a fluoroscopy cadaver workshop at this spring meeting, which is a regional anesthesia and acute pain meeting specifically on this topic. So it's a great place. Start with the symposium in March. Watch the demonstrations, watch how it's done, and then come to the meeting in Florida and actually sign up for the workshop. This one's a hot workshop and it's very small. It's only going to be for a select few people. So make sure you sign up for that workshop early, because there's not a lot of spaces and we want it to be something that people really don't feel like there's a big crowd at the workshop. This needs to be a hands-on kind of experience. We have a question from one of the audience listening. Meher K says, please consider PCPs, surgeons, psych, and the management team, and have them speak in our society meetings to listen to their side of the views, their side of the story. That's a great point. Hance, you want to talk about that a little bit, about how you guys incorporate the entire team and it's not just the pain physicians involved?
Yeah, I always say, Raj, the easiest part of this gig is the pain side, in terms of, I can give you medication, I can put a needle somewhere, but I think the heavy lifting comes down to in particular, our psychologists to teach pain coping skills. We have a full-time psychiatrist in the program now as well, who helps us obviously with some of the interactions and deals with a lot of that trauma that many people come with, whether that's, their childhood trauma that they bring, sexual trauma, you name it. All of these things lead into folks that struggle. So this is much bigger than a pain physician sitting there and helping someone kind of deal with their acute to chronic pain. There's so much complexity here. And I always call these patients the complex pain patient, because that was how we actually got our initial funding from our ministry, was to say that there's something different about these folks that go on to struggle, and it's a multidisciplinary approach. And so this is the mainstay of how we built the program, and I totally commend this person who asked the question. And even with the program that's been built here in March, this is certainly a part of what we're going to talk about with Beth, I think, being part of the program, and the buprenorphine conversations and some of the other issues. In the first symposium, we had our physiotherapists gave a session, we had occupational therapists. So this is kind of the extension of what we've done in the past. So thanks for the question or the comment.
Yeah, and just getting to this symposium, I mean, there's, you're going to see people who have MDs, of course, but you're going to see MBAs, you're going to see nurse practitioners, PhDs, in different kinds of specialties, different backgrounds that bring a variety of perspectives to the problem. And what you'll see in the ASRA meetings coming up, both the spring and fall society meetings, is that you will see, and it's a transition, we're growing in this regard. You're going to see more neurologists, surgeons, patients, psychiatrists. We have our fall meeting coming up this year. The chair of the meeting is PM&R physician. He's got a background in PM&R as his primary educational track. So we are trying to expand that conversation because we realize that the team is big and everybody's involved in the conversation. And the more multidisciplinary the effort, the more effective it is. And as all of these guys on the show can tell you, no program works in their institution without the full multidisciplinary effort. So thank you for that question. It's really relevant. And for those of you guys who are trying to do it on your own, that may be where your hang up is. You got to get the whole team involved and invested in this process. Primary care physicians is one we don't actually talk about enough, I think. I mean, my wife is a primary care physician, and that's a big part of her practice is people dealing with pain. And I think that they should be included in the conversation more. I don't think we go back that far back into the conversation, but we should. I always tell people that we're only going to keep this to 30, 40 minutes. We've already been 35 minutes. So, it just time flies when we're having a good time. I don't want to keep everybody too long. I do want to give everybody a chance. If there's something that you suggest that people really pay attention to at this meeting, just one pointer to take away from this meeting, from this symposium, why don't you give that point out, and then we'll wrap up with that so that people know to kind of find this meeting and get something that they can actually take into practice with them. So Dave, I'm going to start with you. Just a thought as far as like, if you could say like, this is the one thing I really want you to take from this meeting, what would you suggest to people?
Well, probably the one thing I'm going to be focusing on a lot, and it's kind of the intersection between the acute and chronic pain specialists and our training, and how do we cross-pollinate each other so that we're learning from each other and our fellowships aren't so different, that we're coming to the same plan for these patients.
Hance, how about you?
Yeah, I think one of the biggest things is we're now in a space where this is no longer a nascent concept. This is something that many people are gravitating to, building transitional pain programs to help these patients in that time of transition. And I think that, one of my regrets per se wasn't focusing enough on potentially those interventional aspects that I could have brought in earlier. You can't do everything, but this is a moment where, if this is of interest to you and you want to learn some techniques and think about, I have this patient who's a month or two into their journey, and we're obviously doing some opioid weaning and implementing other medications, but maybe here's a technique I want to try to bring in. If this person has a thoracotomy, I want to try an ESP block or maybe a peripheral nerve stimulator. Who knows? But this is your opportunity to try to get a grasp of how you might do this.
And Hesham, what any main points you want people to get across when they're thinking about this meeting? One thing to look for in the meeting that they can take home with them.
Thank you for your time, Raj. It's actually a first step because it's a complex, it's an air gap, and maybe in the future it would be like a new subspecialty. So it's first steps maybe to establish a new subspecialty in the longer term.
Yeah, this is a growth area and definitely something that we're just beginning the conversation on. So I want to remind people, this is the Chronic Postoperative Pain Symposium hosted by our Perioperative Pain SIG, Perioperative Persistent Pain SIG. It's a special interest group, and this is March 11th, and you can register right now on the ASRA website. So I encourage you to go there and put this on your calendar. And then I'm going to show a couple of links at the bottom and hashtags. So this is asra.com/SIGs/PPP. So this is the group that all these guys are part of. They're one of the most active special interest groups in our organization. They do a phenomenal job. I encourage you to go to that, sign up, be a part of it. And then follow hashtag ASRA PPP SIG to see any conversations surrounding this group of people. And then ASRA.com/PPS is for the symposium. So we try to make it as simple as possible to get to this registration page. And that's hashtag ASRA PPS 23. And then again, just a reminder, this is March 11th. So make sure you get to these places. I think you're going to love it. I really want to thank all three of you guys, not just for joining me today, but for putting this together and the work you guys do in your institutions to help these patients. I've been doing acute pain management for over 16 years now, and I have literally felt that gap that we didn't have anywhere to send people after we had done a tremendous job taking care of them in the hospital. And I knew there was a cliff on the other side of it, and we just didn't have a good way to hand these patients off. So I commend you all for putting this together in your institutions and hopefully inspiring people to put it together in their institutions, because I think there's definitely a need here. But thank you for joining me today. I always love talking with you guys. Hopefully we'll get to see you all in person very soon at the spring ASRA meeting in Hollywood, Florida. And all of you guys, thank you for joining us tonight, and we'll see you again soon. Have a good night.
Thank you very much, Ray. Thank you very much for attending, and see you in the symposium.
Excellent.
Thanks, everyone.